Thank you for the kind invitation to give this talk. My name is Mathieu van der Jagt. I'm a neurointensivist from Rotterdam, the Netherlands, from the Erasmus Medical Center. And I work at the intensive care adults. And I want to talk to you about hemodynamic management in subarachnoid hemorrhage patients and what would you monitor and in which patients. So you could say circulatory management in subarachnoid hemorrhage and in neurocritical care is a hot topic because there were a lot of consensus statements, guidelines, viewpoints, reviews published in recent years. And I want to discuss some of the guidelines and new evidence which is available. In going through these guideline recommendation, I want to discuss with you whether these older guidelines from 2011, 12, and 2013 still are up to date, or if there's new evidence and we should consider changing the guidelines. So I want to discuss updates on evidence. And in the end, what this talk is about, what should we monitor and in which patient. So first, the American Heart Association guidelines from 2012, they state that maintenance of euvolemia, normal circulating blood volume, is recommended to prevent DCI. I think this is true, but the statement of euvolemia and normal circulating blood volume is a little bit puzzling to me. First of all, because I don't really get the difference between euvolemia and normal circulating blood volume, or are they the same? I'm not sure. And in these guidelines, there's no true definition of euvolemia or normal volemia. So I think for newer guidelines, such a definition should be added. In 2016, I published a narrative review on fluid management in neurological patients. And my suggestion was to define normal volemia as an intravascular volume that sustains the required cerebral perfusion for adequate brain oxygenation. So then we continue with the guideline recommendations. And they state that accumulating literature has shifted the focus from this SAH therapy to the maintenance of euvolemia and induced hypertension. So how did we do it in the earlier days? We know from many case reports that in the earlier days, dehydration was the main goal of these patients to prevent cerebral edema. But in these times of dehydration, where patients had a low fluid intake, antihypertensives and diuretics, or it was not mentioned in mostly observational case series published at the time, when these patients got hemiparesis and DCI, they were actually having this on top of being hypovolemic. So then when volume was given, like here, a bolus of plasma, or when blood pressure was increased, or a combination of both, then the patient could easily improve. And that was seen as proof for the fact that we should give the patient a lot of fluids and augment blood pressure in combination. But I think that may not be true at this day and age. However, because of this signal in the earlier days that fluid and blood pressure augmentation might improve the patient or might decrease the symptoms of DCI, this was investigated in later trials. These trials by Egge and Lenihan investigated whether prophylactic hypovolemic therapy or SAH therapy could improve outcome. These trials actually found that hypovolemic therapy did not improve CBF, did not improve outcome, and did not improve fluid balance. What they did do is that they, the patient in the hypovolemia group had higher fluid input, significantly higher, almost 5 liters a day, instead of 3 liters in the control group, and the CVP, so the central venous pressure, was much higher in the hypovolemic group. However, although there was no benefit in the hypovolemic group, there were much more side effects related to this fluid overload, like pulmonary edema, myocardial infarction, and other complications. But actually, what we aim for is euvolemia according to the guidelines. Hypovolemia may be easy to recognize and prevent, for instance, by looking at the diuresis of the patient, so how much fluid output the patients have. But hypervolemia is less easy to recognize in a patient. When should we stop giving fluids? That's much harder, I think. So we go on with the guideline recommendations. It is stated that administration of large volumes of hypotonic fluids and intravascular volume contraction is not recommended after SAH. And that follows from the older studies I've discussed. And monitoring volume status can be done by a combination of central venous pressure, wedge pressure, and fluid balance. However, I think for this time we should also prevent large volumes of isotonic fluids, not only hypotonic fluids. And regarding monitoring of hemodynamics, I think CVP and wedge may not be very practical, and there's also data not supporting that in every patient or in at-risk patients. And fluid balance might be important, but I will discuss this in the next few slides. This is from a review from Nino Stacchetti's group, and it's to show that when there's a breakdown of the blood-brain barrier, then even even when there's no hypo or hypo-osmolar solution in the bloodstream, then isotonic fluids may easily leak through the disrupted blood-brain barrier. And of course, SAH patients can have a disrupted blood-brain barrier. So the problem is that when there's a breakdown of the blood-brain barrier, there will be edema formation even when there's no hypotonic state of the blood, of the serum. So that means that when you give a lot of fluids to the patient, and fluids that the patient might not really need, then that may lead to cerebral edema. So on another note, we should discuss the venous side, and venous congestion. So this is the model of Guyton of the human circulation. Blood is circling around from the pump to the arterial side, so this is the heart. The capillary bed of the organs, in this case the brain. Then there will be a venous outflow to the venous capacitance vessels, and you have the stressed volume, which actually constitutes the venous return, and the preload of the heart. And you have the unstressed volume, which does not contribute to the venous return. So what can happen when you give too much fluids? Then you may have venous overload, and that can actually impede the outflow tract of the brain, and that can contribute to cerebral edema or decreased cerebral blood flow. So a little bit go into the venous problems that can occur from some clinical studies. This is a study by Mensch and others in critical care medicine in 2007. They did sequential interventions in 10 SAH patients with disturbed autoregulation, and they found that when inducing hypertension, then the cerebral blood flow and the PbRO2 increased. This is HH is hypervolemia and hemodilution when they applied so this is actually volume loading, then CBF didn't go up and oxygenation actually worsened. And when they applied Triple H therapy, the cerebral blood flow improved, but the oxygenation did not improve. So based on these studies, they postulated that induced hypertension is probably the most useful intervention to increase cerebral blood flow and oxygenation, and not so much giving fluids. What's important to come back to the venous outflow problems is that in these patients with volume loading and with Triple H therapy, they measured that the CVP, so central venous pressure, went up to 20 or 25, which is very high and actually constitutes, in my opinion, venous congestion, which may certainly affect the brain. But otherwise, there are not so much studies, especially in SAH patients. There are some studies in other patients. This is a study in cardiac arrest patients where they looked at the central venous pressure and showed the association between higher central venous pressure and decrease in cerebral tissue saturation with NIRS. When you have a higher CVP, you have a lower cerebral blood flow because of the outflow tract impediment by a higher CVP. So you can approximate CBF by subtracting CVP from the mean arterial pressure. And actually this number was also strongly associated with bad outcomes, so with poor outcomes. So when CVP goes up, then the outcome of these patients was worse. And actually in the trials by Lennon and Egge, you saw that hypervolemia was associated with a very high CVP. We did a recent survey with other investigators in a worldwide survey among 145 centers where SAH patients are treated. And all the colleagues that were surveyed actually said or filled in that they targeted euvolemia, 96%, that they aimed for a neutral fluid balance in SAH patients, and that fluid intake was maybe 2 liters a day in some patients or otherwise in other patients, but 3 liters a day of more or more was not given according to the people we asked. However, we know from data from the Conscious trial, these are data unpublished with courtesy to Professor Locke MacDonald, that actually there was an enormous variation in mean daily fluid input on a center level. So the mean daily fluid input could vary in these 50 centers that participated in this trial from, let's say 7 liters every day to maybe 1.5 liters every day. So there was an enormous variation. So my guess would be that the idea of the participants that they had a neutral fluid balance and they didn't give too much fluids, that may be a little bit different in reality. So could we improve this situation with possible hypervolemia in many patients? Well, I think we can. We implemented a new protocol many years ago where we start to treat these patients with PICO to titrate the fluids based on fluid responsiveness. And this is based on the simple fact that when you give volume and the cardiac output or stroke volume increases, then you have a state of normal volemia, or at least not yet hypervolemia. And when you have a non-fluid responsive patient, meaning that when you give volume that the cardiac output doesn't increase anymore, then you know that you should stop giving the patient fluids, because then the patient's not fluid responsive anymore. And there's more than enough preload in that situation. So this is an example of a patient we treated with the PICO. So we gave 6 liters and the patient peed also 6 liters and the fluid balance was 0. And we started with PICO to measure cardiac output, which was good, and fluid responsiveness. And then we stopped giving so much fluids, and the patient still had a fluid balance of 0 and just started peeing much less. We investigated this in 23 patients, and we saw that when installing the PICO, we stopped giving many fluids. So we gave much less fluids, but what happened also is that the patient started having significantly more diuresis. So this might indicate the venous congestion, because when venous congestion goes down, also the venous congestion of the kidney will be better, and the kidney start peeing more. And Glasgow Coma Scale, after giving much less fluid, did not decrease. After installing the PICO, we also saw that patients were still hypervolemic and fluid overloaded, because the global and diastolic volume index and extravascular lung water was still much higher than the normal values. So the patients were still hypervolemic, and this means that over here before the PICO, they were very much hypervolemic, I would say. We also saw in a larger cohort and also in another study by another group that there was an association, especially with fluid input in SAH patients. So for every extra liter of fluid input per 24 hours, there was a 20 to 30% increase in the odds of DCI. And this association was not so clear for fluid balance. So when we give, as doctors and nurses, when we give much more fluids, this seems to be associated with an increased chance of or risk of DCI. So luckily there were trials by two groups. The group by Mathieu did a trial with the PICO-based management in SAH patients some years ago, and they found that with the PICO, they started giving less fluids. So this is the input and the output, and the black bars are the patients treated by the PICO monitor, and they started giving less fluids, and also the patient has less output, but the fluid balance was the same. And they also found less DCI vasospasm and a slightly better outcome. A similar trial was repeated last year in a German group, by a German group in adult SAH patients. Same principle, treated with PICO versus a control group. And what they found was actually quite similar, a much decreased incidence of DCI, and much less cerebral edema. Also, they gave less fluids in the PICO group, and DCI, you see here the Kaplan-Meier curve, was much less in the goal-directed therapy group. We did a meta-analysis on this for Dutch updated guidelines for SAH, and we found the clear signal that late cerebral ischemia and neurological outcome and pulmonary edema was less in the PICO-guided group. A similar signal we found in another study recently published in Lancet Neurology from the Center TBI study, where we found that incrementally positive fluid balance was strongly associated with worse outcome, and the same signal was there for more fluid input. So what about anything else from the guidelines? So I'm going to go very quickly through this because of the time. We're now at 19 minutes. So what do the neurocritical care guidelines on neuromonitoring in SAH say? So monitoring of cardiac output may be useful in patients with evidence of hemodynamic instability, but based on the PICO trials, I think you should consider cardiac output monitoring also in absence of hemodynamic instability. With pulmonary edema, we should avoid excessive fluid intake, but I think we should always avoid excessive fluid intake. No specific modality can be recommended for monitoring, but I think PICO is a good choice based on the newer trials. Isotonic crystalloids is preferred fluid agent. but I recommend you to read the nice basics trial published in New England Journal of Medicine, where they compared balanced crystalloid versus saline in critically ill adults, and found that in especially neurologic patients, balanced crystalloid may be a little bit better, but in traumatic brain injury, balanced crystalloid are actually not better. So this is an interesting signal. Giving boluses of fluids can be done, but you can also apply blood pressure augmentation or just put in a pico to measure cardiac output. And regarding the transfusion criteria, it is stated in the guidelines that SAH patients should have other transfusion thresholds, but I'm not sure I agree because there's no evidence to support that assumption. And I'm currently also a participant in the TRAIN trial, trying to investigate the best cutoffs of transfusion threshold for hemoglobin. So what should we monitor? To finalize, you can also have a look at a consensus summary published in 2014. I think it's a wise comment to say that you should do hemodynamic monitoring to establish goals that take into account cerebral blood flow and oxygenation. In the same consensus is also a flow chart, which you can read. And how we do it in Rotterdam is that, especially when there's pulmonary edema or when there's cardiac dysfunction or a very negative fluid balance, or when we just simply are afraid that the patient might develop DCI or is admitted to ICU, we have a very low threshold to start using PICO. So in summary, what should we monitor and in whom? This is what we should monitor. We should consider hemodynamic monitoring in any patients, I would say, especially high risk, and when a patient has an ICU indication or is critically ill or comatose. Invasive hemodynamic monitoring can be done. There are several options. You should consider strongly to do hemodynamic monitoring in neurogenic pulmonary edema or stress cardiomyopathy, and if possible, use cerebral monitoring to titrate hemodynamic therapy like autoregulation, ICP, and other monitors. Thanks for your attention, and good luck with the rest of the conference.